As promised on this video, we're going to talk about pulmonary vascular disorders, including pulmonary embolism and pulmonary arterial hypertension. PEs are pretty common, unfortunately. There is a risk for them if you've had any kind of surgical procedure, if you have heart failure, if you have taken birth control pills, especially if you take birth control pills and you smoke and you're in your late 30s or 40s. If you've taken anticoagulant therapy for any reason in your life, of course, you're always at risk for further problems. They usually happen, believe it or not, pulmonary embolisms usually happen because of a DVT in the lower leg. Now, if it is a blockage from an artery, like a fat embolism or an air embolism, that's a little bit different. But what you will see most commonly is a PE caused by a DVT, and those DVTs are usually in the lower extremities. You would think if you had a DVT in your arm that it would go to the lungs, but they don't, not nearly as often as the ones from the legs. Biggest sign and symptom of PE is sudden onset of sharp chest pain and panic. The patient will not be breathing well, they'll cough, they may have blood-tinged sputum, they may become cyanotic, they will have severe chest pain and be tachypnic. They might go and have signs and symptoms of shock. Usually, at least at the onset, there is no change in their lung sounds, but eventually they might develop a friction rub, maybe some crackles. If not treated, the patient's pulmonary function will decrease. Again, its onset of panic is probably the most, chest pain and panic are the most common signs and symptoms. It's diagnosed with CT and also a D-dimer blood test are the two most prevalent diagnostic tools. If it's a horribly big pulmonary embolism, it clogs the pulmonary artery or pulmonary vein, the patient can die very, very quickly. So it's nothing to mess with ever. It's treated with thrombolytic agents. Usually the patient is started on either heparin or some sort of heparin derivative like Lovenox. And if it's, depending on the cause of the PE, sometimes they'll put in a Greenfield filter, which is basically like putting in a colander that looks like an umbrella into a vein up by the heart, and that catches all the clots. The patient will then be moved to, after they're stable with heparin, they'll be started on Coumadin therapy or some sort of oral anticoagulant therapy. Depending on where the start of the PE was, will depend on the treatment. But these patients will, if they have a DVT in their leg, we're not going to put SCDs on them, but we will put TEDs on them. Ambulation, if it's a PE, they will have them ambulating, exercising, deep breathing. It all depends on the start of where the clot is. If the clot is really huge, once in a while they have to be surgically removed, but that is extremely, extremely rare. And also, again, if it's really huge, they might use TPA like they do with a stroke, but again, very rare that that happens. Pulmonary arterial hypertension is elevated blood pressure in the pulmonary arteries. So remember what the pulmonary arteries do. The pulmonary arteries go from the heart to the lungs. And what happens if the pressure in the pulmonary artery builds up, remember you always look for the buildup behind where the accident is. So that means that there is resistance in the blood flow, like what can go in and out of the right side of the heart, and whatever's happening in the lungs is stopping them from getting a good transfer of the blood. So it's very, very rare that you will see pulmonary arterial hypertension, very, very rare. Occasionally there's some issues that might cause it. Back in the day when people were taking fen-phen as diets, diet pills, that or diet drugs that was causing a lot of pulmonary hypertension and actually killing a lot of people. There was actually a nurse at the hospital that I worked at that died from overuse of fen-phen. So you have to be really careful. You have to educate your patients very well, especially if they're taking any kind of drug that in any way constricts the vessels. Signs are shortness of breath, fatigue, chest pain. Eventually the right side of the heart enlarges, and that's called cor pulmonale. Again, this is pretty advanced stuff in PN care. Even as a cardiac nurse, I've seen this issue maybe once or twice, and in both cases that I can remember, it had to do with drug use and overdose. So don't worry a lot about this disorder. Just know that it can kill you. And with any respiratory illness, at the first sign of tachypnea, dyspnea, chest pain, anything, intercostal breathing, accessory muscle use, that's an emergent thing. And as long as you remember that breathing, ABCs, it's the A, and the B. So make sure that you kind of direct your nursing care that way instead of getting specifically involved in a lot of the details of the illness itself. Treatment is done with diuretics to reduce cardiac output. Anticoagulants are given because if the ventricles get overloaded, then you can throw a clot. They'll use calcium channel blockers, maybe beta blockers to vasodilate. Beta blockers, they have to be very careful because what happens in the vascular bed does the opposite in the lungs, and they don't want to congest the lungs. So they're going to probably stick with calcium channel blockers. If this is caused by some sort of disease process, like a familial or genetic disease process, lung transplant might be the only real cure for it. Okay, then there's trauma that can cause all kinds of issues with the lungs. Pneumothorax is basically, let me put it in simple terms, when the lung, behaving like a balloon, it pops, air gets into the pleural space, and so then there's no negative pressure. And the lungs can't expel air properly, and there's backups then in the hearts. The vessels just get all backed up, and it's quite a mess. Sometimes they happen spontaneously with a disease process. Pneumothorax happens a lot if you have a chest injury, and they're usually obviously, if the patient's impaled by a tree, that would be an open pneumothorax. If they're bruised and bent, that would be a closed pneumothorax. And then a tension pneumothorax is usually caused by just too much pressure. And then there's like this medial sinus shift, so you might see a tracheal deviation, and we can talk about that more in class. The lungs collapse because the pleural space filled with air. They can also collapse if it's a hemothorax. That means that the pleural space collected with blood. You'll see that in trauma a lot. And it's diagnosed with a chest x-ray. And again, that pleural space is the lubricating area that allows the lungs to go in and out. And if there's not a good negative pressure flow and the diaphragm can't suck out, then either fluid or air will develop. Here's some pictures of what it might look like, a collapsed lung. You can see how much smaller it is. Again, take a balloon, take the air out of it, and that's what it looks like. I suggest that you YouTube pneumothorax, hemothorax, all of these different things just to get a really good baseline visual. But again, what you're going to be worrying about is the nursing judgment. So what are we going to do? What's going to happen? Like, you're going to walk into the patient's room and find them. Very, very rare that you would find a patient in the hospital with a pneumothorax unless there was some sort of surgical issue or something like that. But again, what are you going to do? ABCs, you want to keep the tracheal straight. It's an emergency. Um, Docs are going to come in, they're going to relieve that pressure and relieve the pneumo or hemothorax as soon as they possibly can. A chest tube would probably be inserted. The patient's going to be in a Fowler's or semi-Fowler's position. They're probably going to be, these are the patients that are really struggling to breathe, so you might see them posturing a little bit. And they'll, of course, be on O2. And depending on where, what the cause of it is, that pleural space might become sticky. And that's pleurodesis, and it's very, very, very painful. So drugs will be given for that before they do any kind of procedure. Sometimes the lung has to, once they've fixed the problem, once they've fixed why either the fluid or the blood or the air was there, the lung has to re-expand. Sometimes this happens quickly, but sometimes it takes a week or two. So that patient is really going to have to be doing some exercises to get that lung reinflated without putting too much pressure on it. Next issue that you might see commonly, car accident victims, if you're in an ER, sometimes when old people fall and they hit the side of the bed, they fracture ribs. If you have to do CPR, I don't know if any of you have done CPR on a real life person yet, but just prepare yourself that when you do, you will probably break ribs. And it feels really awful. But when someone fractures a rib, depending on what it does, obviously it can cause a pneumothorax, a hemothorax. Very, very painful, not only outside like a broken arm. I mean, a broken rib has that same bone pain feeling, but every time the patient breathes, there's a risk for a pneumothorax or a hemothorax. Treatment is to prevent any complication. You want to prevent a pneumothorax. You want to prevent a hemothorax. The use of binders, it used to always be use a binder, but now they don't do that because then the patient's not breathing completely, and then pneumonia happens and so on and so forth. So that's a controversial issue. Of course, we want to encourage slow, deep breathing, use of incentive spirometry, and pain medications. By now, we're now on slide almost 60. I think you probably realize that there are patterns with the nursing care on all of these issues, and that is what we're looking for. Yes, different issues have different treatments, different medications, but our nursing care is almost always the same. So let me see if I can get flail chest in on this slide, but flail chest occurs when two or more ribs are fractured and they are kind of free floating. Imagine how painful that would be. When you take a breath in, your chest is supposed to go out, and when you expire, your chest is supposed to go in. But that happens the opposite with flail chest. These patients are almost always intubated in flail chest, and again, imagine the pain. But you can kind of see here, they call it a paradoxal respiration. So your lungs are doing the opposite of what they're supposed to, as are the muscles. So that is flail chest. Our next slide we're going to talk about, our next video, we're going to talk about full-out respiratory failure and hopefully finish this up. I hope you're not bored to death. I hope you're taking good notes. And remember, focus on nursing care for each of these issues.